Welcome, everyone, to the La+Jolla+Cosmetic podcast. I'm your hostess, Monique Ramsey. Today, I am welcoming back to our podcast Dr. Hector Salazar. He's a board-certified plastic surgeon, and he is one of our favorite guests to have on the podcast because he knows a lot about a lot of different things. So today, we're going to welcome him back and talk about something that affects a lot of men, but maybe they don't talk about it too much. And that is gynecomastia and male breast reduction. So welcome back to the podcast, Dr. Salazar.
Hey, thanks so much, Monique. And no, it's always a pleasure to be here and be invited, and especially with that type of introduction. My God, can we do this daily?
Sure.
That would be good.
We can talk about everything.
There you go.
So you've talked about a lot of different kinds of breast surgeries, but we've always been talking about women in the past. And today we're going to switch over and talk about aesthetic breast surgery in men, or maybe saying chest surgery is almost a better word. And so the word for the condition is sort of a catch-all for a set of conditions, is gynecomastia. So what is gynecomastia, and what does that word mean?
So the origin of that word comes it's a Greek origin, and gynekos, or it's like related to female or women, and then mastia comes from the word chest. So a feminized chest or a female chest, and that's pretty much exclusive. The way we use that term is exclusively for men. So women have breast, and it's a normal condition, and it's also a normal condition for men to have breast. But when that breast tissue is a little bit more, it's present a little bit more than normal, or a little bit more than what it's desired, then it's called gynecomastia, a male chest that resembles a female chest. So that pretty much is what gynecomastia means. But that's the precise, you're correct, that's the medical term to describe this entity. So I can go a little bit deeper into anatomy, but that's it.
Okay. And what causes this?
So as I was saying, it's completely normal for male patients to have breast tissue. That's completely normal. It's as a matter of fact, and I know that men, we are not aware of male breast cancer, but by definition, if a male chest can have breast tissue, then we're also exposed to have breast cancer. And but it's of course not as frequent. Men, we have very small amount of breast tissue in there, and it's also not being stimulated by hormones and the way that a female breast tissue is being stimulated throughout the cycle. So, as I was saying, completely normal for men to have a little bit of breast tissue that fluctuates within the different stages of life. So you can see, if you think about a pediatric patient, you think about a man who's a young man, is a boy that's going through puberty, that you can see that there is the development of some sort of a breast bud. They start growing a little bit of like a little small tiny boob right there, and but then that with time tends to resolve, and sometimes that happens after puberty or at the beginning of puberty. It depends. And but some patients actually, they still have that tissue, and that tissue persists after this stage of developing. And that's uncomfortable. That patients sometimes find it aesthetically not pleasing, and makes patients have a hard time when they're wearing the classic description is when you're wearing a polo shirt. It's for some reason, the shape of the polo shirt accentuates gynecomastia significantly. So I would say that's the polo shirt test for patients to see how comfortable they are with their male breast tissue. If they don't care, then that means that it's a very, very little breast tissue, or if it's something that they dislike, then potentially it's something that they can look into.
Now, the American Society of Plastic Surgeons reports that 40 to 60% of men are affected by some level of gynecomastia. So that's like half of all men. Do you think that's accurate, or do you think it's age dependent also?
Well, yeah, exactly, because we're bunching up pretty much everybody as man. and yeah, in terms of different ages, different percentages, but it truly reflects what we were talking about, right? It's completely normal for men to have some breast tissue, but the important part here is how much is okay, or how much are you comfortable having. So true gynecomastia by definition speaks about the breast tissue content, but as well, like in patients that have a little bit of overweight and then they accumulate a little bit of fat, well, we get them or mix them together in the concept of gynecomastia, and we call it sometimes gynecomastia, but in reality, there is a fat component. Every time I assess a patient for gynecomastia, we try to make or differentiate between how much of that tissue is fat and how much of that tissue is actually breast gland, or the presence of a breast tissue there per se, and because that's going to impact the way we treated it. But yeah, no, I mean, it's high incidence.
I remember back in my teenage years knowing a friend who had got real, I guess, gynecomastia, because at that point, when you're a teenager, you're slender typically, and more fit, and he really didn't want to take off his shirt at the beach, or, felt really, really uncomfortable. And so in that case, do you find that when you're correcting younger men, it tends to be more of the glandular breast tissue that you're talking about versus fat?
Yeah, that's right. I would say when you see let's say a fit, well worked out body, you can still find sometimes some true gynecomastia, meaning being true gland. And then when if we talk about some, let's say, on the other end of things, like a non-athletic, maybe gentlemen in their 50s, 60s, then you can find a little bit more of a fatty tissue mixed with some glandular tissue. But the fitter, the younger, and if we're talking about gynecomastia, the more true breast gland tissue you're going to be finding. One of the things is, I think your question is really sharp because the way we see, or the glasses that we use to see through when we're evaluating these patients, there have to be very, very, the correlation between the specific case of that patient, meaning how old, how fit, what's the body weight, are there any other conditions of health, et cetera. We always have to take all that into account. It's not just a mere like, oh, yeah, you got gynecomastia, let's go to the operating room and take care of it.
Gotcha. So what kinds of things as a surgeon, have you seen that men do to try to kind of minimize or hide their boobs, man boobs, before they come to you? Like, have you seen any, I don't know, do they wear like compression garments, or what are the tricks that men can do prior to taking care of this problem? It's something that, as you're saying, it really becomes something that they think about every day. I mean, they live with their body every day. They take showers daily. They look at their body, and it's some part that they would try to avoid when they're looking in the mirror because they don't like it. And they would love to have a better shape. So, things that can help shaping that is, number one, using baggy clothing, trying to avoid to take off their t-shirts, trying to avoid to go to pool parties, go to the beach. And you see in some instances that our patients that are exercising or have a good weight, and they try to do everything possible, but still that tissue persists. Now, there are certain things that can actually make you prone to develop gynecomastia. One, we talked about it being a teenager. That makes you prone to have gynecomastia, right? So in terms of intervening or operating on a patient while they're teenagers, it's a no. No, because most likely, and it can resolve, maybe not, but most likely it's going to resolve after that period of time. The second thing is, if patients take certain medications, one of them, it's called Lasix, one of those spironolactone, and like special medications that we go over a list with, like in case the patients are taking it, that they can make them prone to develop gynecomastia. Another one is, for instance, marijuana.
smoking marijuana can actually make you prone, or eating those edibles, or like certain things can also take you there. Some habits that you have. The other thing is, and we see this in patients that exercise a lot and that they're very and fully dedicated to the gym, but then they also take steroids. So taking steroids can also derive in gynecomastia. So you have like this beautifully well-built body and this very dedicated and well-disciplined person that has developed gynecomastia. And sometimes they realize it, they learn about it, they stop taking those steroids, and then what ends up happening is later down the road, then they still have that residual tissue, even though they already stopped taking the steroids. So of course, modifying all these different factors can also help you see if that gets resolved, but then if not, then there's always the help that we can provide.
Now, you mentioned age and teenage years. So do you have a minimum age for treating gynecomastia?
Well, I would say pretty much those the teenage years. I wouldn't suggest. So let's say that because patients develop at a different pace, at a different rhythm. So if you say like, no, I stopped growing already and I'm like 16, 17, but I hate this, I would highly suggest to wait until you get rid of that extra factor. So if you say like, oh, I'm 20, I'm 21, I'm 22. I mean, you're not growing, you're not developing at that point in time in the same way. So you have a mature, fully developed adult body that is not now being subjected to that wave of hormones, and then you can start addressing it at that point in time.
Okay, and then you were talking about exercise, and is there any exercise that can really improve? I guess if it's fat related, maybe some exercise might benefit a guy, but if it's got breast tissue glands, is exercise ever going to help?
Well, no, because if it's, as you're saying, if it's fat related, so if your component is, let's say, 80% fat, 20% gynecomastia, most likely if you exercise, you tone your pectoralis major muscles, everything's going to resolve and it's going to look so much better. But the problem is if it's 80%, if it's 80% gynecomastia from tissue and not from fat, and if you tone it, I mean, you tone your muscles, you lose that weight and everything, the only thing you're doing is you're accentuating and showing more and more that tissue that before it was like a little camouflage by everything else. But now that you have toned your pectoralis major muscle, and then you have removed all the fat around it, now you truly are going to be seeing that and feeling that gynecomastia. As a matter of fact, one of the moves that I ask when we are examining the patients, I ask them to put their hands on their hips and then contract their pectoralis major muscles to literally mark the gynecomastia tissue, and then we can really feel it and localize it. So the more toned you are, the more you're accentuating that gynecomastia. So does it go away on its own? I mean, after teenage years and after you stopped whatever was stimulating it for some time, and if it's still there, it's not going to go away.
Got it. Now, just like women, we all have different, every woman's breast is different, what they look like. And so when we talk about, the nipple area and the areola, I guess, maybe, I don't know, we use these things interchangeably as lay people, but, sometimes the nipple area is more puffy. And is it that true also with gynecomastia, where that nipple area is puffy?
Right. So let's say if we're talking about a male patient with gynecomastia, and gynecomastia is pretty much all the component is fatty, it's going to be distributed pretty much everywhere in the chest. If we're talking about that this is more glandular, that this is more true gynecomastia, and it's going to be much more localized towards the center, towards where, like right where the nipple is, where the nipple areola complex is. And the reason for that is, remember that the mission of the breast tissue, regardless, male or female, supposedly would be to produce milk and be able to get that milk out through the ducts, through the nipple. So if it's pure gynecomastia, it's always going to be behind the nipple and areola, bigger or smaller, but always back there. And sometimes that works as an advantage to us, sometimes a disadvantage. And we'll talk about different shapes and different things and different techniques that we have. But yeah, absolutely. Creates a puffier areola. Yep.
Okay. And so really, let's dive into that now. That, ways that you as a surgeon can approach that male breast and they want it smaller. What are the different ways that you have to accomplish that?
So I would break it into two big worlds. And one world would be doing liposuction. Liposuction, right? We always think liposuction of what? Of fat. So fat responds really well to liposuction, but breast tissue, it responds to liposuction, but it responds partially. It not always responds in the same way because it tends to be tougher tissue. Well, we can all imagine fat as like a little fluffier. And then when you put in your liposuction cannula, then the fatty part will respond more and the breast tissue part will respond a little less. So on one hand, we have intervening with liposuction, very tiny incisions. When we do liposuction, we scoop things out. And then what we want is the skin and the tissues around the area to shrink, right? Because the last thing we would like is to remove a lot of that content, but then you get a skin envelope that it's hanging and then you develop loose skin and that's not going to be attractive either, right? And because you're going to probably, oh my God, I looked better before. I mean, thank you so much for removing all that, but what do I do with this now, right?
Right.
And so then on one hand, you have the part of liposuction with, I would discuss in a little bit two different techniques that we can use. Okay. And then on the other hand, we have direct excision. Direct excision means making an incision. Also, you have 2-3 different techniques there. You make an incision and then you scoop things out directly. So you're visualizing all the tissue. The incision tends to be around the nipple and areola. And then you go in, you scoop things out, and then you close that incision. Of course, the one in which you're directly removing things is much more powerful. You have more control. You know exactly what you're removing and the amount. When you're removing with liposuction, you're depending on how much the tissue is giving and how much the skin is shrinking or retracting behind it. Let's break it a little bit, if it's okay with you, Monique, and break it a little bit. So let's say that we have a patient that has more fat content than glandular content. So the glandular content, as we said, is going to be a little bit behind the nipple and areola, and then the fat content is going to be pretty much everywhere. So if we have a case of a patient with those characteristics, most likely, or maybe, doing good amount of liposuction will take care of all of his complaints in terms of contour. If he is a young patient, has good capacity of shrinking of that skin, then that's the most ideal intervention for that patient. If the content of the gynecomastia is, let's say, very fatty, not a lot of glandular tissue, but it's a lot, it's too much, then you start getting worried about, are you going to be able to retract, yes or no? Are you going to be able to shrink as much as I want to for you to not to have that loose skin? And as you know, we perform high definition liposuction, which is a liposuction plus, which is perform regular liposuction and then start edging the muscles, demarcating some anatomical landmarks. And when we do HD liposuction, we get a lot of skin retraction, a lot of skin shrinkage in the right patient. And so sometimes if we see that possibility, then we suggest them to, why don't we start by doing not only liposuction, but high definition liposuction, taking it to the next level and giving that skin better chances to retract and shrink than with regular liposuction. So that's why I was thinking when we talked about liposuction, we have regular and we have high definition. We have used high definition several times on patients that actually are well built already. And the one thing they want is to have that muscle edging a little bit more clear. And we use that high definition liposuction on them. So applying or extrapolating those principles to pure gynecomastia, I mean, we've done it only and purely for gynecomastia high def lipo, and patients are really, really happy as well.
Wow, that's pretty exciting.
It's actually great news, because in the past, when we were not doing that technique, if we would see that maybe the skin was not going to shrink correctly, if we were on that borderline, we would immediately recommend them to go into the other part of the world, other hemisphere, where we are going to start talking about it now, which is to go in and do a direct excision. So when the tissue is localized behind the nipple and areola, and you can feel it, and you can basically say, oh my God, I would just love to be able to help this patient, but just removing, just taking it out. That requires an incision around the nipple and areola, pretty much underneath. That's what we do, following that border between lighter skin, darker skin. And we make a small incision, mark the tissue that we want to remove, go ahead and scoop it out. And we have to make sure that we calculate this part, in which we say, do we think that the skin is going to be able to remold and shrink? And if that's the case, then that's what we should proceed with. We should proceed with just that little scoop out. Then you go into, what about if patients have a lot of tissue that it's not only localized, but it's expanding a little more. It's not only behind the nipple and areola. Well, you can do this same procedure, or you can add some other skin incisions to remove potential excess skin that could be generated after your removal. So then the incision is not only underneath the areola, but also sometimes has to come in a vertical form, or you have to go all the way around the areola to try to get more skin out, as well as you remove some of that tissue. And then you have the other extreme, in which you can, I'm going to ask you to either close your eyes, or we can look, you and I together, at some pictures of patients that really have like a male breast per se. It's not only that it's a little puffy, it's not only that it's a little bit big, it's a breast that even sometimes hangs. Mm-hmm. And in those cases, you have to do a technique in which we call it breast amputation, which is basically creating a large incision to be able to remove all that breast tissue, provide the patients with a flat chest, which is their goal. The price to pay is to have an incision all the way underneath the border, the lower border of the breast, and give them a flat chest, and then go ahead and do what we call a free nipple graft. So the nipple and areola, what we do is we shave it at the beginning of the case, we set it aside, we do the case, and once we have given them the flattest chest, then we go in and we use that as a graft, the nipple and areola. And so that's, I would say, the most extreme case for us to do that. We rarely have to do these cases, but when we have to, then we have the secret weapon to be able to resolve that. And one last, in terms of the techniques, is that we sometimes can combine the direct excision of a specific part with a little bit of liposuction. So also, and that's the reason why it's very important for me to be able to assess and individualize every single case.
Well, that's wonderful. That really kind of, from whatever scope or mm-hmm. On a continuum of, slightly puffy mm-hmm. and to, really excess skin and fat and breast tissue, that there are ways and differing techniques to be able to solve that for patients. And so I would think that, this is something that, while men may not talk about it very much, the ones who do get it done, I would think that they're extremely gratified.
We just two things, Monique.
Now, going into the surgery itself, you have the surgery. How long does it typically take? And I'm sure that really depends on which of these techniques you decide to use. But in general, and what does the recovery look like?
So, in terms of the length of the surgery, can go anywhere from an hour to 3 hours, probably. I would say everybody fits in there within 1 to 2 to 3 hours at the most of surgery. But normally patients recover very, very fast and very well from this surgery. They feel fine. I would tell you probably 2-3 days after surgery, they feel fine. The only thing is this: whoever performs physical efforts at work, then that becomes, they need to take some time off, because for about a couple of weeks, we don't want them doing a lot. We don't want them carrying anything heavy. We don't want them exercising for 2 weeks. And also we want for them to be as compliant as they can with our instructions. And that includes wearing a compression garment after the surgery. It depends. If it's a direct excision, sometimes the garment will need to be used for 2 to 3 weeks. If it's liposuction, then we ask them sometimes to wear it up to 6 weeks, depending on how they're responding. The other thing is, in special cases, when we're doing direct excision, sometimes we need to use drains. I mean, it's something that it's an inconvenience for 5 to 7 days, which is having imagine, and I know that you know this, but for our audience, imagine a little flexible plastic tube, like an IV tube, coming out from where the surgery, the surgical site, and that's to collect some fluid that the body of the patient tries to build up after things were scooped out. Not everybody needs them, but the patients that they need them, we have to place them. And that the only thing that will do is give them a quicker, faster recovery. So who can complain about that? So, but I would say, in terms of how much do I need to take off work? So if you do something that does not require any physical effort, you just need, literally, if we do it on a Thursday, you should be good to go back to work intellectually on Monday. If it's something where you truly dedicate, and I mean, I don't know, let's say you deliver heavy boxes. So I would say probably you're going to need 2 weeks of not delivering heavy boxes. So that kind of gives you, I think, a span of different recoveries for patients. Okay.
And if you're the guy who lifts weights, do they get to do that 2 weeks later, or is that longer sometimes, or does it depend on what kind of surgery you did?
Exactly. It depends a little bit, because if we're just doing liposuction, most likely we're going to let them exercise at 2 weeks, and then they can ramp it up as they need. If we're really scooping things out, or we have a more significant incision, then probably we're thinking about not letting them exercise for 2 weeks. Then after 2 weeks, they can start doing some cardiac work, some aerobic work. And then probably at week 3 or 4, they can start ramping up the weights after that.
Now, are there any visible signs after? So once you're fully healed, your scars are fully healed, depending your incision lines, if you had any, is there any telltale signs that people would be concerned about?
No, not really. I would say that, in terms of for instance, if you think about risks and benefits of this procedure, you think about pretty much the risk that any other surgery, even a small little procedure has, a little bit of bleeding, and you could have a difficulty with your scars, or but something that is really, or it's closely related to this procedure, is as you are taking the tissue out, you can always have either some irregularities. You can always have a little bit of a divot if there's a lot of tissue that has been removed, or your body didn't mold it appropriately or correctly after. But good news is that we continue following up our patients throughout the journey. So we see the patient the next day, we see the patient the next week after the procedure has been done, then at 3 weeks, then at 3 months, then at 6 months, then at a year. And if we see that there is either a small contour irregularity or something that needs to be improved, then we can always do that. And we always work with our patients for that. But so whenever the surgery goes well and all the molding and everything is being followed, then the contour should blend and blends very nicely with the rest of the body, and it looks completely natural.
That's wonderful. And I think, there's people keep in mind that there's always some trade-off, right? Mm-hmm. So it's like, which was better or worse? You might have a small scar, you might have a little whatever, but the difference is that you don't have to worry and be self-conscious in clothing or out of clothing. Mm-hmm. So Dr. Salazar, what kinds of things have your patients said to you after going through this little transformation? That brings back memories. That's like immediately I should have done it years ago. That's one of the things. So like the other thing is like, oh my God, I can see the difference right away. Another thing is the classic is my shirts fit so much better. And the other one is like, thank you so much. Thank you.
So, but definitely everybody gets excited. Everybody enjoys the result. And it's one of those that, oh my God, I should have done it so many years. And now that I see it and I'm so happy, but you know what? I had it done. Now I'm going to enjoy it. So patients they respond really well to treatment and they're really grateful. Sometimes we talk to patients that are, imagine, right? Because not everything is white or black, right? There's like some gray zones in every single thing that we do in life. So as we are talking to the patient, and if we are estimating that the patient has some tissue that it might retract, but it might not retract as much as we want. But so as you were saying, let's give them the benefit of the doubt. So what we do is sometimes say, you know what, if we go in and we scoop it out, you might develop some loose skin. But if we go in and just do liposuction, you might, because there's more of a glandular component, you might have some tissue left behind. So when we are tilting here and there, and so sometimes what we do is we give them the benefit of the doubt. And instead of making a big incision, we make very tiny incisions. We do liposuction. And as we were saying, the fatty part will respond really well. Mm-hmm. The glandular part will respond how much we can't tell, but sometimes what we have faced is we just do that and patients are so happy that was it. We don't need to do anything else. And sometimes what we do is we go in, we do that liposuction, they start shrinking, they look really nicely, they avoid having big incisions, but then they say, you know what, we're about 6 months out, we're about 9 months out, everything has shrunk nicely. I still have a little bit of tissue just right behind my gland. But now we're talking to something that is very reduced, very approachable. You know what? Now, instead of having to do a big incision, what we're going to be doing is just that small incision around the areola, like pretty much it's inconspicuous, it's underneath, and we'll scoop the little pea that was still there. But then they get, it's 2 procedures, of course, but you're talking about what gives you the best possible result. So there are some patients in which we do this and they're always very happy, either because they didn't need a second intervention or the second intervention was something tiny that, oh, you know what? Now it's perfect. So,
pretty minor too, it sounds like. Mm-hmm. And now when you do a consultation for this, male breast surgery, tell us a little bit about what you do in that consultation. What's that like?
Well, it's important, and it's really important. I mean, more than 90% of that gynecomastia incidence that you mentioned, it's just an anatomical variance. It's meaning a nothing. It's just a normal, different breast. I mean, there are tall people, there are short people, there are people with pimples, there are people, right? So they're man with have a little bit more breast tissue. So that's a great majority of patients. But there's a minority of patients that might be related to something else. Might be related either to a habit. It might be related to a medication. Might be related to, God forbids, a tumor, a testicular cancer. I mean, something like, right? So it's important to do. I mean, not lose the focus on the fact that we are remember, I mean, yeah, we're plastic surgeons. Before that, we were surgeons, general surgeons in our majority. And before that, we are physicians, right? We're doctors, we're scientists. So it's important to go and assess the patient, listen to how it presented, when it developed, how long it lasted, what has been done in terms of treatment, any studies that have been done, perform a good physical examination. Remember, I mean, you said it, board certified plastic surgeon. We are all about safety. So we see the patient in a holistic approach, and we make sure that nothing calls our attention or nothing gets out of that norm. So a full physical examination, do a good history. And then after that, then we go into, okay, this is just a normal variant. Let's take care of it. And then we come up with a good plan. We determine which is your profile. After all of these that we talked about, we go over some pictures. We show you where the incisions are going to be done. We show you what exact procedure we're going to be performing. And then we go over potential risks, all the benefits, and the recovery. And usually we're together for half an hour, 45 minutes, or an hour, and we come up with a nice plan, and we clarify all the questions, and then we're lined up for a successful surgery without any surprises, which is, I think, the most important part.
And when we talk about, this range of different options, would you say, could you narrow down to like 50% of the people, maybe a liposuction does the trick? Or are you able to kind of quantify for the audience, like who might be on what edge of, the types of interventions you do?
I would probably say that it would be right on that gray zone, because I would say probably you're going to be talking about, if we want to say how many patients go into lipo versus direct excision. Probably I would say that it's 50-50, if not 55% liposuction, 45% excision, but it's really non-significant because it's right there. Pretty much, believe me, and for our audience and for our patients, believe me that the way we approach it is we try to do the most minimal intervention possible, because that's for sure is going to give us the best result, the smallest scar, and the happiest patient. And then we start going from there. So let's say that in my algorithm, I would love to be able to only do a little bit of liposuction to the chest area, and that's going to give them a great result. But then we start there, and then we start moving. Okay, so what about high definition? Maybe for this patient will be better. Or, you know what, maybe, okay, why don't we try to combine a small excision of the tissue with liposuction? Probably that'll be enough. You know what? No, we need to go in and excise a little more. Well, you know what? Probably the patient's going to develop some extra skin. We're going to recommend a little bit of bigger incisions. You know what? No, this patient for sure is going to be very unhappy with hanging skin. Let's go for the big surgery with the longer scar, and only because we need it. Because, I mean, our goal is to make that person feel much, much better, and they're not going to feel better with loose skin now. So that's pretty much how we work up the ladder.
Okay. And when people are thinking about price, we do publish price ranges on our website because we think that helps you kind of know what you might be looking at. Mm-hmm. But when you have that consultation right after they see you and you come up with a plan, you meet with a patient care coordinator. She will show you exactly, like, here's how much you'd be looking at. Most of the procedures fall in the range of $8,000 to $11,000. But, again, if you're on some edge of the spectrum, it might be slightly different. But we also offer financing. And I think that's a really great way for people to say, oh, this is affordable. It's not one big number due tomorrow. It's, it might be $200 a month or something like that. And so we work, I think this is so interesting. We did a study within our own practice, and, we've been around for 35 years, and we've used financing for at least 30 of those years. And we noticed that really it doesn't matter what year it is, 1 in 3 patients utilizes some sort of financing. So it's very normal, and we're used to talking about it. We have lots of different companies we work with. Patient Fi is one of the ones we go to, and, they'll do a soft credit check. You don't have any, big penalty for seeing if you would qualify. So that's kind of a nice thing to know about. And then, Dr. Salazar, if the patient doesn't live in the San Diego area, and I know you work with patients who come in from out of town all the time, do you still provide the virtual consultations for those people?
Oh, absolutely, because that makes it, that's going to get us 80% close to the final diagnosis, to the final approach for which treatment you're going to need. Of course, there's nothing that's going to be substituting a good in-person physical examination. And as I tell sometimes the patients, like I say, like, I would love to be able to be there and virtually do a pinch here and virtually, right, like pull it up and bring it down. But at least it gives us, and opens up the discussion. Patients we can understand what their goals are. They can learn our philosophy. They can feel comfortable with us. And also, we can start planning their surgery and get it really close, as you're saying, to which part of the spectrum you are, how many hours. It's all about how much time is going to take, right? So, you're more of like minimal intervention, almost to nothing. You're more into like, big incision is going to take about 3 hours. So it'll give us much more light, and it's a good way to get things going. If you say, well, what about if they come in and visit? And how long do they have to be here after the procedure? It also depends on how much we're going to be intervening. Sometimes if it's a good liposuction, probably I would say that they can be here. If it's regular liposuction, as long as they're here 3-4 days, it's fine. If it's high definition liposuction, they have to be here for about a week. If it is a direct excision that it's minimal, probably about a week, it's fine. If it's something that it's a bigger incision, more tissues being removed, probably an ideal of 2 weeks is what's needed. But
that's also the rejuvenation vacation.
Exactly.
Right.
Exactly. And what a better place to come to than San Diego.
Come to La Jolla, stay along the golf course up there at Torrey Pines, and enjoy.
That's right. One thing that I would like probably to add is, if you're listening to the podcast and either you are the patient or you are a family member, take that step. It's not, as you can see, you get a feeling, right, Monique, of how we are at La Jolla+Cosmetic through this podcast. And then nothing is judgmental, because that some patients sometimes like have that barrier. Oh my God, what are they going to think about me? What are they going to they have a man boob. Number one. And it's like, it's normal. It's completely normal to have breast tissue. That's what we said. The difference is the amount. But so you'll see that we're pretty approachable. We are patient focused. That's, the patient satisfaction, as you know, is the center of our practice. And we are extremely professional, and we love to work in a very safe environment. So we want patients to have the best experience. So even if you just want to come and talk to us, or set up one of those great Zoom appointments where we can get things going and we can give you an idea of what we're looking into. And I think, do it. Talk to your family member, talk to your husband, boyfriend, cousin, or brother, or whoever you feel you've been listening about this with, and tell them to come in. And if they want you to come with them, do it. And if they would rather come alone, that's also fine. But it's important for them not to have that barrier of like, oh my God, I'm going to be so embarrassed, and they're going to body shame me because this is right. A man should never have any breast, right? No, get that idea out of your mind.
Right. So I think that's wonderful, Dr. Salazar, that you're able to, discuss it, because it is totally normal, and it's something that can be fixed, and let's just talk about it. Yeah, well, thank you again. It was really nice to have you share your knowledge and some of the experiences of your patients. And, if you're listening today, check our show notes, because we'll have links about, scheduling, how to schedule a consultation. They're free. So, we're not going to charge you to talk to you. And about financing, you'll see your reviews for Dr. Salazar, reviews for the procedure itself. And you'll see before and after photos. Check the show notes for the links. And of course, you'll see on our website, there's a ton of information. So you can learn about board certification. You can learn about operating room accreditation. We have 360 virtual tours. You can look around our OR. There's a lot you can do. So thank you again, Dr. Salazar. Thank you all for listening, and we will see you again on the next one.
Take a screenshot of this podcast episode with your phone and show it at your consultation or appointment, or mention the promo code podcast to receive $25 off any service or product of $50 or more at La Jolla Cosmetic. La Jolla Cosmetic is located just off the I-5 San Diego freeway in the Zymed building on the Scripps Memorial Hospital campus. To learn more, go to ljcsc.com or follow the team on Instagram at ljcsc. The La Jolla Cosmetic Podcast is a production of The Axis, TheAxis.io.